they randomized people with erectile dysfunction into two groups. One group got Viagra, other group got placebo. In the Viagra group, 72% showed clinical improvement in sexual function. What about placebo group? 50% showed clinical improvement. P was statistically significant, and Viagra went on to become one of the hot-selling articles in the Pfizer market. What are the difference? Things change. Things change in between. From a deductive model, we have gone into what is called as a probabilistic model. Statistician entered the scene, and did it make it more clearer or not? That you have to decide. But one group which helped a lot, was cigarette company. See what happened at that period. This guy, Bradford Hill, and his friend Dorr, they started doing a study on smoking and lung cancer. And cigarette companies knew they were in trouble. And what they did was, they employed a consultant. Always smart thing to do, employ a consultant. And this consultant's name was Robert Fisher. Have you heard of that? He practically wrote the textbook of biostatistics. He was the cigarette company's consultant. Now, like many people those days, Fisher smoked. He enjoyed a cigarette. Number one, he was not very highly paid, okay? But cigarette company had a lot of money. So when this whole study came up by Bradford Hill, Fisher stood up. Let me get it straight. You think smoking causes lung cancer? Mm-hmm. Well, does every smoker develop lung cancer? No. Does it? Yeah. Is every lung cancer patient a smoker? I rest my case. It is neither necessary nor sufficient cause. So according to your own textbook, written by Robert Koch, doesn't work. So Bradford Hill had the hard task of saying, we have to look differently. We have to have new ways to look at causality, because otherwise this is not going to get us anywhere. Now there's a guy called, his name, David Hume. Have you ever heard of him? He's a brilliant guy. He's from Scotland, and he spoke with a heavy Scottish accent. Have you ever heard a Scottish accent? As the only accent funnier than a Malayali accent. Okay. And so this fellow said, his problem was this. You can never make out cause. Don't even try. By observing, you can't make out causal relationship. He's ascribed it to, this is the way it argued. Supposing there's a switch, I put it on, light goes on. Put it off, light goes off. After 10 times, will I say, this switch causes the light to come on? Can I? How do you know there isn't another nut sitting in the other room fiddling around with another switch? Hey, that's very hard, isn't it? You take a lighted matchstick, bring it close to your finger. You can see the matchstick, you can feel the pain. But the burning matchstick caused the pain. You are making up in your mind. There is no logical basis. When you hear it, you get angry, right? But the man had a point. Many things happened around you. You put on one and say, that is the cause. This is the cause. In other words, he said, coincidence, chance, all can be reason for something looking connected. They are not connected. How do you rule out all other possibilities? So it's a very intricate argument, very convincing, but to make a long story short, there was another brilliant man that time. His name was Karl Popper. Karl Popper was probably the most intelligent human being that lived in the last century. He had written extensively. He said, this guy was right, David Hume. You can't prove, but you can only disprove. Now, I'm going to shorten it and say, how does it work? The way he suggested is, you argue there's no cause. It's all by chance. Okay? And then start looking for evidence. If you can't explain this can happen by chance, then you say maybe there's a cause. Okay? I know it is complicated, but I'm going to come to that. I have to explain what is chance and how do you prove it is beyond chance. Both are important. But basically, we are going into a new era called a probabilistic model of causality. Okay? And underpinning the whole thing is the notion of null hypothesis. A null hypothesis which firmly believes everything works by chance alone. Okay? And now, that is the part you got to clarify a bit. Chance. What is chance? The course of a coin, head or tail. What is the probability of head? 50%. Or a tail, 50%. I would have thought that's a perfect example of a chance. Till I heard Sunil Gavaskar chiding Ganguly for losing the 5th toss in a row in cricket. You know, Ganguly was the captain. He lost the toss. Again, next time he lost the toss, and he lost the toss. And 5th time, Sunil Gavaskar was livid over the radio. I could hear him. This is what's wrong with Ganguly. He has gone and lost the 5th toss. Why? That's what Ganguly never practices. So the other commentator said, Sunil, what do you mean practice? You can practice how to throw it. Anyway, I think he was so angry, he would have cursed anybody. But believe me, it's purely by chance. Let us demonstrate. See, you can't see this coin, but you have to believe me. So I'm tossing it first time. That's a head. Wow. Second time, there's a head. Third time, I got a head. And 4th time, I got a head. 4 heads in a row. This is my lucky day, I think. Now I'm going to go for the 5th toss. 5th toss, just like what Ganguly did. Now tell me frankly, will we head or tail? Remember, on an average, you have to get 50% of the time head, 50% no. I've already got 4 heads. Now what is it going to be? Tell me honestly, head or tail? You're not supporting Gavaskar, okay? Yeah, that is chance. Chance is cruel. It is mindless. The knowledge of what happened in the past doesn't help you in future. And that is the basis of chance. Cannot fathom it. Cannot quantify it. Did I say cannot quantify it? Cannot measure it. Did you hear me say it cannot measure it? But that is chance. So believe me, tossing of the coin is chance, but I'm going to do something different. I'm going to ask her, because she has not spoken whole day, I'm going to ask her to go out with a coin. And toss, toss, toss. Do you know how many times you have tossed? 100 times. That is the punishment for not talking. Now, when she comes back, each of you can bet 1,000 rupees. And I guarantee, if you win, you get 1,000 rupees. If you lose, you lose 1,000 rupees. You understand? But I may create 5 boxes. Box number 1 is A is equal to less than 20 heads. How many heads? That's what you have to bet. Okay? Less than 28, less than 1. B is equal to 21 to 40. C, 41 to 60. D, 61 to 80. E, more than 80. You can place your bets on any of the 5 boxes. After some time, she'll come with one number. What number will be? Number of heads. In a brown envelope, nicely sealed. Okay, and we'll open, and the payback time starts. But before I do that, let me check with you. Where will you bet? How many will bet on A, B, C? Wow! Even she's surprised. Now look at that. Something absolutely chancy. But you are so sure you're going to bet here. Okay. Out of complete, out of control situation, now you are able to quantify chance and say this is a higher chance than the other. In other words, chance can be measured, quantified very accurately. And that is what gives us a hope in our whole endeavor to study cause. So how does the thinking go in causality? Everything is purely by chance. That is my fundamental belief. It's called the null hypothesis. So you do the experiment and you have a result. And the question comes up, does it fit in with the prediction by the chance? If it does not, then you say there is something wrong. For example, if she comes with all tail, what would you do her? Says, let me see your coin. Okay? That can't be a regular coin. You know it can't be chance. Well, under chance, anything can happen, but you can make educated guess. Okay? So generally, we don't bet on small chances in science. People's lives are involved. Okay? So very rare thing, we don't go by. So the underpinning all our scientific thinking in causation is this concept of, is it something beyond chance that we are seeing? And all the statistical analysis just go by the same rule of this business. What is expected of chance? Is it really away from what is expected of chance? How much is the difference? And if this difference is big, then the probability this can occur by chance alone is very low. But to proceed into that era, you need to start asking this question. What do you look for in causality? Smoking and lung cancer, let's say. What do you expect? Smokers to have more lung cancer than non-smokers. But to do that, you need two sets of data. One, incidence of lung cancer among smokers. But that alone is not good. You need incidence of lung cancer among non-smokers. No comparison group, no study of association. So Bradford Hill came out with a logical approach to studying causality. He said, first ask the question, how strong is the association? And in studying association, we use only one parameter for all practical purposes. For our class, that is called relative risk. Do you have very risky relatives? Some of them are, right? Yeah. But relative risk is a term which explains the ratio between incidence among exposed by incidence of unexposed. If it is 1, what does it mean? Incidence among It's both the same, so there's no association. If it's more than 1, it's a risk factor. Less than 1, it is a protective factor. So 1 alone stands there as a guard saying that there's no association. Okay? So our question always in our statistical thing, we have to have 2 groups. One group is exposed, another group, comparison group, not exposed. And then you study the strength of association. For example, smoking and lung cancer, the relative risk is 15. Okay? Smoking and heart disease, the relative risk is 1.6. What does it mean? It means that when it comes to causality, lung cancer is very causally related. But smoking and heart disease, the association is not that strong. Okay? So there are only 2 rules in epidemiology. No comparison group. That's rule number 1. To study association, you need a comparison group. No comparison group, no association. That's a rule number 1. Rule number 2, never forget rule number 1. Okay? I had a good student who finished my classes and went back. Somebody asked him, hey man, how's your wife? He said, as compared to what? Now that's a good student, okay? So any question you answer, as compared to what? Now, I would like you to take up that little paper called appendix in your handout. Appendix. There's an easy problem. Do it back. Oh, do just the first page. Don't do the back. So you calculated incidence among smokers, incidence among non-smokers. What are the numbers?
1
120 per thousand incidence among smokers. We call it A. For this word 1.6 into excess risk. Pardon? 60% excess risk. Now that sounds good, right? So when you say if you eat fried food, there's an increased risk for stomach cancer. How much? 60% excess risk. I don't think I should eat fried food anymore. But you're talking about a lousy 1.6 relative risk. Even a very weak relative risk like 1.25, you convert into excess risk. 25% excess risk. You all sit up and listen to the guy. Because there's so many people doing studies, so many epidemiology studies, and everybody comes out with the relative risk. Most of them very close to 1. Exactly 1 is tough to get, okay? So you get very close to 1. And then you convert into excess risk. So I heard people going hysterical over 10% excess risk. What is that? 1.1 relative risk? Awful. But one problem. It works up to about 1.9. But supposing your relative risk is 2.1, then what happens? Excess risk become 110%. People look at it, what is 110%? You know? If your son came home and said, Dad, I got 110 out of 100. Now I know his mathematics is really bad, right? Okay. So, excess risk people understand within the framework of 1.1 to 1.99. And they use it left, right, and center. All I want you to remember is this excess risk, which is commonly quoted. Any journal article, they'll be talking about excess risk. Is talking about weak relative risk. Don't fall for it. In causality, in public health practice, we use all kinds of things. But in causality assessment, you have to ask for decent relative risk. And what is decent relative risk? Something that looks decent. 2 to me looks just about bare decency. Okay? Right. Now, I finished with the excess risk, and I'm going to go through this thing called risk difference or attributable risk. Incidence of smokers is this, incidence of non-smokers this. This is 3%, this is 12%. Now, what is this shaded area? That is the amount of disease the smokers would have had even if they had not smoked. Right? Because non-smokers had none. So, essentially the argument here is, this is the amount of risk that can actually be attributed to smoking. So, this is called attributable risk, and this is 9%. Or 90 per thousand. That is the AR or risk difference, RD. So, got 2 names for it: risk difference, absolute risk difference, and attributable risk. But in practice, we never present this way, or hardly ever. We always convert into a percentage of the total. We express this as a percentage of the total. So that works out to be 75%. Have you got it? Of all the disease among the smokers, what proportion can be attributed to smoking itself? So that is called, so it's called percentage attributable risk. So when you say this, there is something little nasty about it. We are only talking about smokers. Among the smokers, 75% of the disease is due to smoke. So when you go to a minister and say, listen, we have to get rid of smoking because 75% of the disease among smokers, so he said, don't tell me about smoker. In my population, in my country, what proportion of the heart disease is because of smoking? And that is called population attributable risk, PAR. And gave you the equation for that. I didn't derive it for you. You got it? And that is proportion exposed. You should use it as a fraction into RR minus 1 divided by PE into RR minus 1 plus 1. So I'm going to give you a sum, not what's given there. 50% of the people smoke, 50%. And the relative risk is 2. 0.5 into 1 divided by 0.1. 0.5 divided by 1.5. That is 33%. From a public health point of view, an extremely important parameter. That's how we prioritize. Let me give an example. Drinking and driving, does it cause accidents? How important is the problem? If you say something like relative risk, no minister or no secretary will understand what you're talking about. Relative risk 10, so what does it mean? But you convert into population attributable risk. Population attributable risk depends on what? A, relative risk. B, proportion exposed. How many people drink and drive? Let's take an example. The actual calculation was done. Relative risk for drinking and driving an accident was 10. 10. Proportion driving in Indian today at night, drivers who are at the moment is about 20%. 20% certain parts of the time. Night driving, you take 20% would have had alcohol. So proportion exposed is 0.2. Calculate population attributable risk.
94. 64. 64%.
They are not agreeing with you, no? Nasty people, what to do? That is a huge population attribute risk. You know what it means? If you take away drinking from driving, there will be a 64% reduction in the total accident, an important parameter. Okay, we understood the approach to the whole concept, but causality is not merely establishing how strong is the association. And Bradford Hill came out with some guidelines, and it's available everywhere, but listen to me anyway. The thing he said is, make sure every time, if there is a dose response, then it's very powerful. See, whom do you have to convince? Another human being, other scientist. And one thing that human mind appreciates a lot in the context of causality is dose response. See, what happened to the cigarette companies is they told Bradford Hill, see, listen, smoking doesn't cause lung cancer. What happens is some people have very allergic lung. There's a lot of immune cells, and they don't develop lung cancer. But they also, when they try to smoke, they cough and sneeze, and they don't pick up cigarette smoking because the lungs are too allergic. But others with a hardier lung, less immune cell, but more prone to lung cancer, they happen to pick up smoking. So, smoking doesn't cause. It screens people who can get lung cancer from those who can't get lung cancer. I think Fisher was behind this thought process. He's like a very devious mind. So Bradford Hill's response was to show a dose response curve. How much did non-smoker have? How much did 1 to 10 cigarette have? 10 to 20, so on and so forth. And as you increase the number of cigarettes, the lung cancer rate shot up exponentially. And he said, don't tell me this is some screening. It is really poison and respond. Okay, that is a very convincing evidence. The third point you should worry about is you should be able to demonstrate that the cause came before the effect. And believe me, it's not always easy. There was a case of ranitidine as a cause of stomach cancer. So whenever they did a study, they actually showed that people who had taken ranitidine had a higher risk for stomach cancer. But then they asked the question, why the hell are these fellows taking ranitidine? Oh, they had a funny feeling in the stomach. Hey, that's the early sign of stomach cancer. Funny feeling in the stomach. So wait a minute, which came first, ranitidine or the stomach cancer? That problem has to be solved. Anyway, I'm going to show you some data from my program. This is on our antenatal services and perinatal mortality. Have you heard of perinatal mortality? All of you, perinatal mortality. Who is dying? The baby, the mother, or the father? What is perinatal mortality? Some of my ears are not picking up the sound waves. Death of baby. There are two types, stillbirth and early neonatal death. Stillbirth is all fetal loss after 28 weeks, and early neonatal deaths are within 1 week after birth. And here is the data on perinatal mortality, stratified, disaggregated according to number of antenatal checkup. A and C, less than 4 to 5, 6 or more, 60, 40, 20. Is there an association? Yes. Higher rate of mortality for those who didn't have antenatal checkup enough. More. Is there a dose response? Yeah. With increasing number of antenatal checkup, less and less perinatal mortality. Now, temporal ambiguity. That's what I'm trying to get across. Now remember, usually a pregnant woman comes to antenatal checkup around 18-20 weeks. That's when she's convinced she's pregnant and she thinks that she should have help. Then the next visit may be about 26 weeks. Then she has a stillbirth. Will she come for annual checkup? No. Most perinatal deaths in the newborn are because of prematurity. They come out too early, too small. So now think again. Is ANC reducing perinatal mortality or perinatal mortality reducing ANC? You understand the causal connection is no more very clear. So this, pardon? So this you have to worry about and make sure in your study design this doesn't become a nut difficult to crack. If somebody says we can't make out which came first, cause or effect, your whole case is gone. Now all these things are in your notes, okay, but the next one is consistency of evidence. People studying all over the world find the same kind of result. Then you say, yeah, possibly there is a kind of a, this must be true. But be careful, there is something terribly wrong with the way we do research. For example, in most medical colleges, our PGs get a topic. How is chosen? You look at an international journal and then you find something and tell the PG, hey, I want you to do this as a thesis. Yes, sir. Don't mess it up. No, sir. Okay, he goes. And then, finally, he gets the results upside down. Completely contrary to the publication. What would the boss say? I knew you're an idiot and I shouldn't have given you this topic. You messed it up. Okay? The PG is smart, he'll go and sort of redo it, massage it, and then probably bring it to shape. If the study actually reflects what is in the original data, the boss will be very happy, pat him on the back, and write to the original author, dear Dr. Fox, we also did the study, we also got the same result. So the consistency is very often got what is called a publication bias, and and then people keep repeating the same damn thing. And you have to be kind of cautious about that. Well-done studies from good centers, you can trust them, yeah, then it's fine. For example, I was just reading an article by, this study was done in Mexico, okay? I've never been to Mexico. Do I know anybody from Mexico? No. So I have no anger, no animosity, nothing. But it is from Mexico. Now, this study is on association between vitamin D and forgot. Anyway, it'll come back to me later on. Anyway, this study, when you see some studies, there's a black hand moving the thing behind the scene, and then you walk away from it. But that wisdom we need. The next item in the agenda is biological plausibility. This is probably the most important factor in deciding causality. How is the biology behind it? If you can't explain the biology, then causality is suspect. Okay? And that is the important part of it. There's a syndrome, the pediatricians are familiar with Reye's syndrome. Reye's syndrome is a dramatic condition. Children get it, and they get convulsion, and they become sick. They have hepatomegaly, hypoglycemia, they are toxic, and they usually have a poor prognosis also. You know what the cause they found? Baby aspirin. I have a problem there, okay? How do you explain those few molecules of acetyl salicylic acid can cause all these huge changes? Then you ask the question, why the hell was the mother giving him anyway aspirin? some indisposition, right? So now it'll cause. FDA did not say aspirin is banned for baby, but they put a warning. Be careful, because consistently studies showed aspirin. But biological plausibility seems a little funny. Do you understand when I am saying biological plausibility? I'll give you a crude example, not a nice example. My colleague was interested in acupuncture, so she wanted to go to Japan. I don't know which way it worked. He wanted to go to Japan, so she said she's interested in acupuncture, or the other one now. Anyway, she went there. After some time, she came back with all kinds of needles. Okay? So I watched anxiously. So she said, if this needle you put on your right big toe, the pain in your left headache, left side of the head disappears. I said, lucky I don't have any headache. Now, I've seen this happening. People love acupuncture. All over the place they do it. Is it a strong association? I guess so. But I know, is there a dose response, more needles, more pain relief? I don't know. Anyway, they come with various needles. Consistency evidence. The whole China, Vietnam, Laos, everywhere they use it. I only watched once, in Bhutan. This guy was treating patients. One of the main problems Bhutanese have is sexually transmitted disease, okay? And this guy used to keep all the needles in his mouth, okay? And then take one by one, that is the way sterilized acupuncture needle. Now, all this I said for fun part. But my friend is a physician. She knows how to autoclave. She did it practice. But my problem is, I couldn't explain the biology behind it. Why should the needle reduce asthma? Why should the needle reduce pain? Now, I'm not laughing at acupuncture. I'm trying to explain to you the meaning of the word biological plausibility. There should be a plausible mechanism how you can explain. Till then, I, for one, will be careful. I wouldn't be really carried away by. For example, I don't know, they say many cricketers, if they hit a century, they never change their socks. Same socks they wear the next time. They believe it is magic, okay. Now I can understand that, magic, but no biological plausibility. They lose friends, that's a different matter. But and next one Bradfield talked about is something called what is it? Do you have that paper with you? Causality? Huh? Causality, the small list.
Coherence.
Coherence of evidence. Oh, you haven't got the coherence of evidence. What is that? You have to pay attention. It's a little difficult to understand what coherence of evidence is. See, none of us come with a clean slate in our brain. We already know about the world, many things about the world. So the question is, does the new information sit pretty in the context of the already known stuff? Is it harmonious with your knowledge you already have? Otherwise, you resist it. And say, I can't believe this can be right. And I think you have a right to do it. Okay? So, for example, there's a condition called MODY, maturity onset diabetes of the young. So when it came initially, everybody was confused. MODY, and they didn't have the name MODY. People used to call malnutrition-related diabetes, and all kinds of names they had. Finally, I think it settled for MODY. So people are doing research as to what the cause of MODY is. And one group from Kerala came and told me, "Sir, we have found the cause." I said, "What is it?" Tapioca. You know what tapioca is? In Africa, they call it cassava. Tapioca. It's a starchy tuberous root. Grows wild in Kerala anywhere. Okay? In fact, Keralite, by a definition, is somebody who eats tapioca. I have never seen a Keralite who does not eat tapioca. It's a cultural thing. If you say, "I don't like tapioca," they'll throw you out of the state. Okay? So I was quite worried. How did you do the study in Kerala? You need diabetes among tapioca eaters. That you can get. Diabetes among non-tapioca. They don't exist there in Kerala. Okay? So I was looking suspiciously. But the issue of coherence comes from this context. I also have Modi in Vellore, and there is no tapioca there. So I, for one, won't believe the tapioca story. Okay? So that is what I'm saying. Sometimes you can conclude in your deterministic fashion, yeah, this can't be right. There's something wrong with this argument. And so that is what is meant by coherence. And in that list, finally, I put specificity of association. This is in memory of Robert Koch and his teacher Henley. It says, a particular agent must cause a particular disease and not a whole lot of disease. Then you get nervous. What the heck is happening? Or reverse of it, a particular disease must be caused by a particular agent and not a whole lot of stuff. Difficult to get it, but we can't forget, Robert Koch. So we put that specificity of association. The only thing I know closest to it is mesothelioma and asbestos. We hardly ever see mesothelioma except in the context of asbestos. Okay? So we have a framework of looking at causality, not a complete one. It's much more complicated. The modern thinkers in causality has come into a place called from deterministic causality to probabilistic causality. But now they are moving into a new era called a modified determinism. In the modified determinism, you don't have causal factors, but rather a constellation of causes. And when they all work together, the probability of disease is 1. That is the hypothesis. If you know all the ingredients of the cause, then you know there must be the effect. For the time being, we still are engrossed in probabilistic model. So if you show me 1,000 smokers, I'll be able to calculate how many of them will develop lung cancer in the next 5 years. But I will not be able to tell you who will get it, who won't get it. That is the weakness of our causal thinking. Within the framework, we have to do it. Okay? Now, I have to give you an exercise to do, and that is called exercise on clinical trial. On a vaccine trial. Why was the informed consent obtained?
It's a baby is 3 to 5 years old. Consent was obtained from child.
Yeah. Yeah, but the circumstance you have described But what is the logic saying that why should you take informed consent?
Parents are responsible for the well-being of the child.
That's right. So you're focusing on the fact we are taking it from the mother or whatever. But why informed consent at all?
Parents must be aware about.
There are two
The parent must be aware about the risks that may cause
Huh?
vaccination. Parent must know the risk of vaccination.
Right, safety and well-being.
And because this is a new vaccine, it is something new given to any child in the community or whatever is available. The parents should be aware of this.
Yeah. But still I can't understand, why don't you take children? You love children, don't you? Give some vaccines, some placebo, finish the study, don't involve the mother in it. Unnecessary anxiety for her. What's your problem? Yeah. Okay. Answer loud, clear. Speak up for yourself. Yeah, speak.
As one of the important vulnerable groups, so children have been approached. And it is still likely that the safety might outweigh the benefit. I don't know if that's really like so that is usually one of the outcomes.
Okay, I'm going to paraphrase what you guys said. Yeah, you want to say something? They have a right to choose. Okay. So, let me put it in a crude way. Things can go wrong, right? So if that happens, we can always tell the parent, I told you, right? Is that the reason? You want to save your skin, right? All your answers so far sounded like you want to save your skin.
Parents should realize the importance of the study and completing the. That's why I'm considering.
It's good to have parents on your side.
There's some chance of undesirable.
Exactly what I said. So if you already told them it can happen, then you are not blamed. I told you, nah. Is that the reason? Documentation, that is important. But there is a spirit of asking for informed consent. Somehow is not coming out.
So they participate.
So this is
Knowing they make an informed decision. Knowing it's voluntary.
So we explain them the pros and cons, the different risks, so that they can make their choice. They will participate in that.
That's fair. I mean, you want them to be involved in it after complete understanding of what's in. The whole thing about the question is around the ethics of clinical trial. And the moment you say the word ethics, in India we have a big problem. Okay? Because what the hell is ethics? So when I became a young doctor and I started treating patients, people quickly fell in love with me. And everybody used to come and want to see Dr. JP. And I said, okay. I was quite happy. And whenever I told them about various treatment options, they smile and say, do whatever you like. After all, you are the God. You are our God. After you listen to that line 4 or 5 times, you suddenly get the feeling, maybe I am God. Okay? And this is the trap most doctors fall into. Okay? There's a big divide between medical fraternity and average person in the community. Because people treat them with reverence. Slowly that is going off. and we deserve every bit of the punishment we get. But the fact remains that reverence is amazing. And the people bend over backwards to please the doctor, be kind to him. We never. We are, His Medical Highness is the exact word we use. So this power divide brings in an issue called ethical problem. Okay? Ethics. Very often a clinical trial is done because the investigator is interested in doing a clinical trial. Okay, the primary objective may not be saving life, but this article coming in the newspaper. So we are on a shaky ground here, okay? Absolutely, how saintly are we? That is the problem. So I want to tell you something about my son, who didn't get into seat into CMC, so he went to another medical college. And then he phoned me up and said, "Dad, they took my X-ray." I said, "X-ray, what?" "Oh, X-ray, side of the face, front view, open mouth view. 3 X-rays." Yeah. Why? My anatomy professor was doing some studies. So if she wants to do a study, let her take her son's X-ray. Why should he take my son's X-ray? No. She said, unless we take the X-ray, they won't be sent for the exam. All the first years lined up and took X-ray. Now, that's called informed consent. Inform them. If you're not doing it, you won't be sent up for exam. He heard it crystal clear, quickly went and did the X-ray. The whole concept of this is about decent human behavior. And how do you practice it, inculcate it, spread it, so the social fabric itself becomes stronger based in ethics and behaving with one another. See, after the Second World War, remember, whosoever wins, finally the winners write the history. So, the point is that they had a ceremony in Nuremberg and they had a court cases all came up. One group of cases, this is called war crime, was what they did to Jews and gypsies. But what the German doctors did, they did ghastly experiments on them, mutilating experiment to study human biology. It was horrible. When they came out, they said, no such experiment should ever be permitted. So the Nuremberg trial came out with the ethical code, which is basically focused on informed consent. Do not do any trial without patient giving informed consent. This is a problem. Informed consent. That's where we get in trouble. Consent we can get. In several devious ways we can get. But informed consent, what information will you give? For example, in this case, how much information will you give? Will you say, if you choose to join the study, your child may get either a vaccine or a dummy. And we won't know, you won't know, we'll study the whole thing. And at the end of it, we'll know whether it protects. Or will you just say, listen, we are having a vaccine trial, why don't you enroll your child? Your child has a good chance of getting the vaccine. It'll be nice, nah? Now, this is the problem. When you talk nicely, you sound nice, you sound like an angel, but you are wicked. Okay? That is not informed consent. And the way to judge is to ask this question: if my child, my grandchild, my wife, or my mother has to undergoing clinical trial, how much would I like to know? And you have to make sure you give so much information. It is not because, God will punish you. It's what is called as decent human behavior. All religions talk about it. Okay. I come from Christian Medical College, Vellore. So there we follow Christ's teaching. And one of the Christ teaching I tell you, do unto others as you would have them do unto you. Have you heard this one? Do unto others as you would have them do unto you. It's in the Western literature, it is given as a golden rule. I was a principal of CMC Vellore. What did I see it as? I was frightened of this rule. I was scared of it. Because if right in front of the principal's office, a boy medical student hugs a girl medical student, and I yell, what are you doing? What is the answer? I'm doing unto her as I would have her do unto me. Not a good rule. But if you go into Upanishads, you have a different version, much earlier actually. It says, don't do unto others what you don't want them to do to you. It's a little negative, but it's called the silver rule. But then we have the iron rule also. Do unto others before they can do unto you. But basically, reciprocatory behavior, that is what we are coming out with. The way you behave, others will behave. And gradually, the society will adopt new norm. And hospitals, medical colleges are areas where these things are stark. People come there anxiously. And how do you treat them? It has a lasting memory. It changes the behavior. So it is not only the fact you cure or not cure, it's also what you do in interaction in a sensitive mind as they bring the babies or children or dear one and how you treat them. So in actual clinical practice itself, we can do all the harm. But in research, you have no business of creating any harm, because you are going and begging them to take part in the study. And you do it with all sincerity and earnesty. And that is crucial in clinical research. So I teach my students, judge yourself. Are you fit to do clinical research? I'll tell you how. Examine yourself. In our book which says, love thy neighbor, love thy enemy. I tried all of that, doesn't work. You get irritated by them. Your neighbor irritates you, your enemy irritates you more. But I learned over time, you can respect others. And the respect is fundamentally the underpinning thing that says, if you respect somebody, you will behave to them decently. And decent behavior is all ethics about. And it should become a religion for us. And if the person has not understood a clinical trial and you enroll them, that's a sin. Okay? You will go to hell. Now, no excuse. So, every country has had their share of unjust practices. Anywhere you look. And we have had also. But in future, I think we should change. Finally, when Supreme Court looked at our clinical trial record, okay, maybe their lawyers who presented well, the people who are against clinical trial, the Supreme Court said, stop clinical trials. You guys are not fit to do clinical trial. So it was banned, all clinical trial. Luckily, they could recuperate and then say, no, this is under some terms and conditions were put, and then you go chronic. But we haven't changed. We still don't get informed consent. You look at your own institution. How many people actually take informed consent properly? No. It's just a side here. That's it. And that is sad. And you should not allow it. It's not only bad for you, it's bad for the community as a whole. Okay, so that is the reason. But there's a more fundamental reason I'll come to in a little while. But this is important. Now, before you go into that, I want to spend a few minutes on this concept of ethics, because very often that we don't pay attention to it. There are four pillars which kind of guide your principles of ethics. One, do always good. Always do good. Number two, don't do harm. Okay, in the process of trying to do good, you may do harm. Number three, respect the autonomy of the individual. Everybody has a right to live the way they want. It's none of your business. And finally, justice. Justice for all is a philosophy that guides us. I told you I used to do leprosy survey long ago, and one school I went and I found 0 cases. I was very happy. As I walked away, I noticed the teacher there, a man, standing, and his face looked suspicious. So I walked up to him and I said, "Hi, do you work here?" "Yes, I teach here in the first standard." "Very nice." I looked at closely. "Can I examine you?" "No." Oh, that is strange. Now, people in my area don't tell me no. Okay, when I said, I would have thought you'll be happy that I'm going to. I said, why not? Because I don't believe in your modern medicine. When I fall sick, I take Siddha medicine. That's a traditional. So don't touch me. I can be very persuasive. And he was a decent guy. He was okay, examine me. I examined him. His ulnar nerves were thickened. I could palpate the radial cutaneous nerve. And even this auricular nerve were large. And the skin had the classical infiltration. So I quickly ran to my van and got my knife and a slide. I wanted to get a slit and smear so that I can see if there are mycobacteria in his dermal fluid. So he stared at me. I told you not to touch. Now you're coming with a knife. I don't know. It's just a scratch. I won't hurt you. After great persuasion, you allowed. So I took smears and my stain was steaming with Mycobacterium leprae. 5+. So I told him, see, I have this excellent medicine. I know Siddha medicine. I learned some. But I know there is no cure in Siddha medicine for leprosy. Remember, I didn't have the gray hair I have now, okay? It was many, many decades ago. So I pleaded with him, I'll give you free medicine. You will be absolutely all right. There's no way I'm going to touch your medicine. So I went to the district health office, educational office. So that fellow called the teacher. Say what the doctor said. Do what the doctor said. And take the medicine. And when he says you can come back to school, then you can come back to school. I'm suspending you. The guy said, there's no way I'm trying to take his medicine. He walked away. And he was there in the village. He fought with his wife and family because he was not working. He was no income. And I think he became a kind of wandering beggar and he went somewhere. How do you judge me? 4 pillars of ethics. Always do good. Well, don't do harm. respect autonomy of the individual, and justice for all. Where do I sin? Guilty or not guilty? Finally, she won't say something. Guilty? Did I do something wrong? No. That's a politically correct answer. Tell me frankly. What do you think? Come on, you're all thinking people.
It depends on angle from which you are thinking. From the societal point of view, as a doctor, from the patient's view.
So we have to look at all points of view. There's no one point. But where do you say? You have to ask the question, did JP do something wrong? And you can say yes.
Partially,
Huh?
persuading him to get treated is good because we know that it's going to work for him. But making him suspended from his work is probably not.
So, I had good intentions. I want to do good to him. Does the medicine cure? Oh yeah. Leprosy can be cured with that triple drug therapy we give, no problem. That's number one. Did I do harm? Oh, tremendous harm. No argument. You won't even repeat it. Every time I say it, I feel like crying that I did all that to him. Did I respect his autonomy? No. I wanted my way. He said, I said, you have no right to behave this way. And what was my defense? The first grade children he was teaching. He was bacteriologically positive and they were exposed to him. So that was the justification I gave. But tell me again, what was the mighty hurry to treat him? Was he the only source of M. leprae in the whole village? Hardly, can't be. Or has he already infected the first graders? Doesn't matter anymore? Possible. Why didn't I become his friend? Why didn't I go for a coffee with him several times? Why didn't I win over? The story would have been different. He still would have had a family and children. So things are not always straightforward. So the ethical dilemma has to be given time to sink in. And to me, I did terrible mistake. And I learned from it, and I was so cautious after that. Because you have to know the thing. Now remember, is leprosy highly infectious? No, it's pretty infectious. Now you'll ask me, where the hell are you talking from? The point is, the guy did a study in Addis Ababa on all the white folks who came from Europe to the Center for Leprosy there. They are mostly Norwegians and Swedish group. They're all coming from non-endemic areas. They took the blood and asked the questions to the lymphocyte. Do you recognize AFB, Mycobacterium leprae? And all the lymphocytes said, I don't understand. After 6 months, when they were about to leave back to their home, they took a little more blood and checked the question, asked the question. And all the lymphocytes blast transformed. They, oh, I know this antigen. What does it mean? Infected. So, don't believe the whole story. Leprosy requires prolonged, close contact. As if to say, lepra bacilli sneaks slowly, come and grabs you now. It gets infected. So if you are an endemic, I work in leprosy. Do you think I'm infected? Yes, of course, must be. Have you ever had a patch? No. That lucky that my lymphocytes took care of it. But infection is gone. And also, even if a child got the leprosy, will he die? No way, I could have cured him. So why did you destroy this man? I'm telling you the story. So think, when you look at ethics, don't take it as some small subject. It has deep meaning, involvement. It goes beyond your little clinical trial. So I think what we can contribute is this. Consider each person whom you enroll into your study, in this case the mother, as your collaborator. And treat him with respect. Don't try to love anybody. Try to respect them. And that will make sure you are doing better. Question is straightforward. When to randomize? Sorry, when to get the informed consent? Before randomization, after randomization? Don't answer. Because everybody will answer correctly. I hate it. Okay? But before you try that, I want to give you a kind of little twist. If you get informed consent, and only some people agree, poor ones, not educated ones, they say, okay, you do whatever you want with the baby. And the educated, well-to-do, no experiment on me. So whom are you randomizing? The consenting people. How can you then generalize it to the whole children? Huh? Now that I said this, now tell me, when do you want to get the informed consent? Before randomization or after randomization? Yeah. Why that? Even though I told you, you will have problem with generalizability, you are going for randomization. Why?
Participation is voluntary, so you have to inform him before.
Oh, no, you should give a logical reason.
To avoid bias.
Avoid.
You cannot include them in the study unless you have an informed consent.
Okay,
Randomization.
let's do one thing. Let's sort out this one. Why the hell do we randomize? Yeah. Tudito. No, answer this. Why do you randomize? Which bias are you talking about? Selection bias. Anything else?
Equal distribution of confounders so that.
Equal chance to.
So confounder control. So that is the reason. So you have. Now, it's randomization is absolutely brilliant. When you randomize, and if your study size is more than 300, when you see the paper, you look at the groups, you will be amazed. You know what? They look like twins. Mean BP, mean height, mean weight. When you look at it, somebody must have manipulated. Yeah, somebody did. You know who? Randomization. Randomization has a brilliant way of creating two similar groups. Okay? And that makes sure the results are top class. But the danger is, if you randomize and somebody say go to hell and goes off after randomization, then you are dead. So dropout is a huge issue in randomizing. Okay? If you have dropouts, randomization gets screwed up. So if you randomize, this is the answer. If you randomize after informed consent, you are safer because they will be there. But if you randomize and then get the informed consent, they say, who asked you to randomize me? Then you have dropout. So the study validity is gone. But as I said about generalizability still holds. So generalizability is one issue, validity is another issue. But if you don't have a valid study, you have no study at all. So better go for a valid study and you worry about generalizability later on. You understand so far? Now, there was a study done in Brooklyn. It was done among gay black population. The study was on the effectiveness, protective effectiveness, new vaccine against hepatitis B. Okay? Now it's found very protective. If now JP wants to take advantage of the protective effect, can I do it? Or should I become a black gay guy from Brooklyn first? Or is it generalizable? What do you think? Huh? The study was done among the gay population, black population of Brooklyn.
It's representative of that population.
Pardon?
It's representative of that population. So you have to become
Okay.
high-risk population.
Your
can
risk,
be represented.
your risk is lower, probably, but the protective effect is based on the physiology, so it should work for you.
So he says, I may not be at risk as they are, but I'll have the same protective effect as them because I'm biologically so close to those black population, indistinguishably. And in fact, there's no way you can do a study on gene and say, this guy is a black and this guy is white or this guy is brown. No way you can say that. Okay? So that close. To appreciate that, you should understand this. One day I got up and I suddenly realized I have 2 parents, 4 grandparents, and 8 great-grandparents. Wow! You're not excited? Well, you should be. I had 2 to the power of 1 parents, 2 to the power of 2 grandparents, 2 to the power of 3 great-grandparents. My thoughts went back to 2,000 years ago. That is 80 generations ago. You know how many great-grandparents I had? 2 to the power of 80. Wow. I have a great ancestry, right? Not only me, each one of you had. That means the earth must have been a very busy place. Do you know what this number is, 2 to the power of 80? It is the number of atoms in the visible universe. Okay? So there's something wrong with my calculation, right? The point is, we are close to each other than we know. We come the same womb, practically. Biologically, we are close. Of course, for reasons, let us repeat the study also in India. I always say, but the results should be same. Because biologically, we are so close. There are genetic variations, I'm not denying that, but by and large, that is it. So the point I'm trying to get across is, generalizability is not a statistical issue, it's a biological issue. For example, I have a new hair oil, JP's hair oil, it increases the length of the hair. My study subjects are student nurses of CMC Vellore. And at the end of 1 month, their hair increased 30 centimeters as compared to control only 3 centimeters. The parachute was the control, okay? Isn't it a good hair oil? Yeah. Now can't I say it'll work on nurses also, medical students also, all other young girls also? Maybe I can't say it will work on those who are above 60 also. That is not biologically extensible. But the main point is, generalizability is not that big an issue, but validity is in most situations. In most situations. I can narrate the other way around also, but by and large. So I agree with you. You should get informed consent. and then only do. Again, in most situations, for heaven's sakes, don't say always get informed consent and then randomize. There are excellent designs where you randomize and then get informed consent for only one group. Very effective design, socially more acceptable, because you randomize, because the study, one group is only standard treatment, so they don't have to be informed. The randomized group, you tell them, instead of A, I do B. Is it okay? And if the intervention is not complicated, they say, go ahead, doesn't matter. So don't go away thinking always you should get informed consent before randomization. For completion, let me write down 3 points for randomization. Avoid selection bias. Avoid confounding. And number 3, what is that? Anybody? Third reason.
Equal chance. Equal chances.
No. That's selection bias and confounding. The third reason is all statistical tests you do at the end of the clinical trial, your t-test, z-test, assumption is you have randomized. So if you are not randomized, you can still do the test, but it's not such a clean thing. The conclusions you draw are approximate, but if you are randomized, your conclusions are spot on. So that's AQ randomizer. In this case, they did something else also. They stratified children according to the presence of a school-going symbol. Why was that done?
School going is a
Risk of getting
Right. That's a powerful risk factor. Remember, the word confounding means that factor is a risk factor. So this is an extremely powerful risk factor. So why didn't they randomize and hope it'll be equal? They trust randomization, but not all that much. So you have a real powerful risk factor, you will stratify it. But as a practice, don't stratify for too many straight. Maybe you are pushed one. Others may be administrative. You stratify for the center, stratify for those. But otherwise, don't try to stratify too many. Randomization will take care of it. What is the next question? Why?
double mark.
Oh, you all know that. Single masking is either the subject or the investigator is unaware of the treatment allocation. In double masking, neither the patient nor the subject is aware of the treatment allocation. In triple masking, nobody knows what's going on. No, we blind the patient. What is the next one?
Why is it done?
Incidence of influenza vaccinated and not.
So you calculated the protective effect? What is the protective effect? Is it 87.5? A. Incidence among vaccinated. B minus A, this part. That is the amount of disease that can be prevented by vaccine from all this. So that is calculated as B minus A divided by B. And then when you divide both top and bottom with B, what do you get? B by B minus A by B divided by B by B is equal to 1 minus relative risk into 100. So that is what it is. But the point we had discussed earlier in your exam or the test I gave you, when you say it is 88.5% protection, let's make it 90, okay, for communication. 90% protective. What does it exactly mean? It does not mean that 90% won't get the disease. It does not mean 10% will get the disease. It means exactly what the picture says. Of all the disease among the unvaccinated, there will be a reduction by 90%. So whatever that is, vaccination produces the reduction in the disease burden. How much? That percentage is what? So 3 doses of polio, let's say, gives you 90% protection. Or 5 doses, 90% protection. What does it mean? In unvaccinated, the incidence of polio is 6 per 1,000. But when you have 5 doses, 90% protection, it becomes 6 per 10,000. That is 90% protection. It does not say 90% children won't get polio. 90% children never got polio. Okay, so that is a myth. So you should remember, protective effect talks about the reduction among the vaccinated as compared to unvaccinated. That clear? Case fatality rate? I have not done it. You calculated case fatality? Of all the cases below a number. Vaccine is called a vaccine. It doesn't mean it can protect. You have to show it protects. So you can ask the same question in the reverse. Is it ethical to give people something without establishing the validity of their intervention? So both are ethical questions. Now there's a condition known as angina pectoris. We medical people are basically very good at creating nice names. You know, the better it sounds, more bill you can put. So angina pectoris is just plain old heart attack. Okay, mild form. Basically, you climb stairs, you have a chest pain. You run, you get chest pain. Your wife shouts at you, you have chest pain. That is angina pectoris. Now, sometime back in the United States, they figured out a way to cure it. Now, this is a good old time. There was no angiography, nothing. Okay, you make out whether somebody has got heart disease, angina pectoris, by asking some clinical question. There are no signs, no way you can make out. But there was a questionnaire those days called Rose questionnaire, which is supposed to be very good at pinpointing who has heart disease, who doesn't have heart disease. Now, so one guy figured out a method of curing this heart disease. He cut open the chest and the left side and identified an artery that runs just to the side of the sternum. It is called left internal mammary artery. And what he did was, he just isolated the artery, clamped it, cut it, tied it, and came out. And patient started feeling better. Okay? So several people tried it. And there was some improvement. So this became started spreading. So some people in the United States said, hey, listen, how does it work? There is the biological possibility. This artery doesn't supply the heart. It's hanging around there. In fact, that is the artery. Now, when you have a heart attack, they borrow and put the bypass in. So they said, we want to do a randomized control trial. So the others objected. How can you do a randomized control trial? It's unethical because this has helped so many people. So this battle went on. Finally, money was granted. They did a proper randomized control trial. Now remember, this is a randomized, double mask, controlled surgical trial. Okay? Brilliant. So people all were enrolled after getting proper informed consent. They were told exactly what it is and said, if you want, you'll be the part of it. Like you said, the way you say it, people should feel excited about joining a clinical trial saying, I also contributed to the science. You can do it when people have adequate education, information, and power. If you don't have power, if you have no education, you can't do this kind of thing. So they underwent, everyone enrolled was admitted to the hospital, and on the day of the surgery, they were prepared and taken to the operating theater. There, every one of them were brought under anesthesia, and everybody's chest was cut open. And then the internal mammary artery was isolated and shown, yeah. Now, the surgeon would say, give me the brown envelope. What is the brown envelope? It is the treatment allocation. Why is it brown? Nobody should look through this and make out what's inside. Complete secret. Because it's a randomized trial. But if the surgeon knows the patient, surgeon may decide, hey, keep the cover, get the other one. So this way nothing happens. You open and show the cover. He says cut it, he'll cut it and tie. Otherwise, he'll leave it alone and come out. Does the patient know which surgery he had? No. One was just opening and closing, other one was cutting the internal mammary. At the end of the trial, the cardiologists were running the trial. Nobody uses surgeons in clinical trial, okay? Because they only know how to cut. So they analyzed the data. They found in the arm where they cut the internal mammary artery, 37% showed clinical improvement. How much? 37%. As compared to the other arm, which was 44%. And this surgery was never done after that. Okay, so the point is, here is a study on an issue that is coming up as an epidemic practice and medical practice, always like that. If a money is generated, they will practice it. Surgery costs money, it will be done. So luckily they interfered and said, hey, do a randomized control trial. From a biological plausibility point of view, there's no way the surgery can cure. And so when the study was done, luckily it was not 37, 44. So most people said, forget it, don't touch it. But you should remember the clinical trials have an important role because they change practice. They bring in new practices. But if it's done well, responsibly, that's it for the larger public good. If you are irresponsible, then that is bad. Okay. Now, we have done very basics of clinical trial. There are more complex things in clinical trial. But fundamentally, the important things we have covered. Now, when you do clinical trials in hospital, we don't have the luxury of hundreds of patients. People admitted into ICU, they keep doing clinical trial, very small number. So the randomization is not always easy. So people use modified randomization schedule. There's a whole family of them. So you should remember, randomization is a very big exercise. But what I want you to do for the rest of the time is to give you a small exercise as to how do we do a randomization. So at least I say, I know how to do it. I've done it before. Now, you have in your handout some schemes given. Forget about that now. And I'll go show you an extremely simple way of doing randomization. What is a block randomization? We ask the question, when one block is completed, within that block, the allocation ratio should be completed. For example, if there are 2 treatment and placebo, the allocation ratio is 1:1. So block size can be 2, 4, 6, 8, or 10. When that block size is reached, the treatment and comparison arm will be perfect. So if you suddenly stop the study, you will be equal characters in both the group. Why do you do randomization? Because of the problem of runs. What is runs? When you randomly allocate, you can get treatment, placebo, placebo, treatment, treatment, placebo. But suddenly, placebo, 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 placebo. Can it happen? Oh yeah, just like the way I threw 5 heads in a row. So it can happen. How does it affect the clinical trial? And this is very subtle, and listen to this very carefully. The paradigm for a clinical trial is a laboratory experiment. In a laboratory experiment, use mice, for example. Genetically identical mice. For generations, they have been grown in the farm. So they are all identical. They look alike, they twirl the little tails exactly the same way. So you randomly allocate still. Put into 2 groups. One group gets tobacco smoke. Other group, no tobacco smoke. Okay? And they both drink same kind of water, eat the same kind of food, breathe the same air, have the same humidity, listen to the same music, all this thing. And then after a period of time, you sacrifice the animal and see how much of neoplasia is there in the lung. And the difference between them must be because of tobacco smoke. So all other things being equal, the difference must be because of the tobacco smoke. All other things being equal. This is the problem. But when it comes to human experiment, humans are not rats. Some of us are bandicoots, but not rats. So how do you create this beautiful similarity between the groups? So randomization, we said. Stratification, we said. We have double blinding so that the information system is not biased. Whole lot of stuff we do. But then the environment changes. PGs are undergoing exams. Number of staff are less. Holiday time. So the environment changes. So when you're doing a clinical trial in a hospital, when you have runs of one kind, that runs will spoil the whole similarity. You want as similar as possible, even the environment. That's why we do blocked randomization. You got it? All right. So now, how do we do a block randomization is the question. There are many, many methods, but there's something very simple. What I do is I have an allocation ratio of 1:1:2. There's a study trying to look at 1, 1. I'll use another one that is actually done. 2:2:1. This study is on aspirin, Pasantin, and placebo. They wanted to know the difference between in platelet addition. Is there any difference? Pasantin, aspirin, and placebo. So I want to create block design. My block size has to be either 5 or 10. Okay? And let's do something simple. I'm going to create a block size of 5. So I got 1, 2, 3, 4, 5. So now you create an initial allocation. An initial allocation is up to you. You can do anything with it. Aspirin, Pasantin, placebo, aspirin, Pasantin. I created the initial location. I control things because the block size is 5 and all the 5 allocation is complete. Now I had to bring in a randomness. So what I wanted to concentrate is, how do I bring in an element of randomness in this allocation of subjects? Yeah? So I need your help. You have, most of your calculators have what is called a random number. Does anybody have a random number calculator? No? You don't have? I will have another method. You have a random number? No. R&D is not. That's all right. You can generate random numbers? No. No. You can.
This is the books with books.
I know.
No. Not that.
Huh?
It can be done text.
No. I'd say the easier one. Now tell me 4-digit number which consists your birthday and month. Can you do that? Tell me.
2587.
25?
87.
No, date and month.
Date and month. 2508.
We don't want anybody's age.
2508.
You.
1812. 1812.
2503. 1108.
2608.
2608. All right. Now we have got 5 random numbers. Would anybody challenge this is not random? It's random. I mean, there's nothing, no pattern, nothing. Except that we have 2 people with the 25th as the birthday. Okay? All right. Now, I marry this number to this. This can be done on a computer. Oh, you got it? That's all right.
Computer, everybody will do it.
You marry this number to this treatment, aspirin. And then I'm going to rearrange the numbers according to ascending order. So I got the lowest number is 1108, which pertains to 812P. It'll be funny if I get the same allocation. Next one is 2503 P. 2508 A and 2608 P. Sorry, Sorry, where did I make a mistake? 1108 aspirin, 18p.
One placebo and
Sorry, I made a mistake here. I should have put, this is Persandin and placebo got confused. This is placebo, call this placebo. Okay? So, have you got exactly the same? No. Why you got 2, 6, and 2, 5? This is not a very successful demonstration. Can you say from there what did I do wrong? I think I'll do one thing. I'll call this placebo and P. At least I have one change. They're not the same, right?
It's the same.
Okay. Basically, what you do is you generate a random number, convert into ascending order, and then rearrange your allocation. But this had to be programmed into the computer so you can develop several blocks. Okay? But the advantage is each end of each block, you have 5 subjects. 2 in placebo, 1 treatment, 2 in other treatment, third one is in placebo. And that is the easiest method we use in college because students can do it themselves with a small computer program, and you generate a whole lot of blocks. And then now you can start the study. That's number 1. The second issue that nowadays we bother everybody is this: is that when you do vaccine trials especially, when you give a vaccine which has a herd effect. Now what is a herd effect? That is, if in a group of people you immunize half the people, those people become immune, but they also block the transmission of the agent. And that blocking protects the unvaccinated to some extent. So what happens? The incidence of disease falls in the unvaccinated also. Now, is it a good thing or a bad thing? Well, the bad part is if you don't know and don't think of it, you do a vaccine trial in a community and you look at the result, you find the vaccine is not protecting all that much. Why is that? Because the unvaccinated are also getting a unfair protection. So when you calculate incidence among vaccinated minus incidence among unvaccinated, that amount is shrunk. So you have a problem. So you need to anticipate ahead. Hey, this vaccine may have a herd effect. In which case, a simple randomized control trial is not allowed. You should do what is called cluster randomized trial in community. There, we do it this way. We create clusters of people within communities. Okay, these are the one block. So you have vaccinated, unvaccinated, vaccinated, unvaccinated, in all the group. Now, if you take one of these, this cluster may be vaccinated. That means there will be people with vaccinated, but they will be living with some people who are not vaccinated. Okay, that is a community. Next community is unvaccinated community. So everybody is living who had no vaccination. So now when you compare, you will find, yeah, there is some protection for the vaccinated against in this area. But when you compare this with this, you will find a even larger protection. And the difference is what is due to the herd effect that you put in. So clinical trials have become complex in the context of other effects that come in. So what am I warning is, this area of clinical trial is really fascinating. It really goes into the amount of understanding we can get. For example, when I was young, we were vaccinating in our area with DPT. And DPT vaccination, see, I belong to an era where we went to the village. The first thing you hear is a whooping cough during the epidemic. And the staccato cough will never leave your ear. And then came this vaccine. And the vaccine, actually, we tried hard to give it. We could never get many communities to accept the vaccine. But by the time we reached 60% coverage, you know what happened? Whooping cough epidemic disappeared. And I sat and said, how come? We have only vaccinated 60%. How come the epidemic went away? I had not heard of herd effect. But here in whooping cough, there's another interesting effect. Vaccination actually affects the way, even when they develop the disease, they infect others less. So there's a multiplied effect. So there are all complicated effects that happen in vaccine trial. And there are many ways to do it. But don't think only clinical trial can bring out all these things. There's the best method. But even case control studies, cohort studies, they also give valuable information on measuring protective effect of vaccine. So that ends the story. Now, but it motivates people. The guy called Cochrane, have you heard of the name Cochrane? Archibald Cochrane. Archibald Cochrane was the chief of MRC, I think, Medical Research Council, UK. And he did tremendous work in improving the quality. And then the whole Cochrane collaboration is named after him. But this guy did a fantastic trial early, and you should know this. This is a time in Britain, most heart attacks were seen and treated by GPs, general practitioners. And then CCU came into being, coronary care units came into being. And he dared to do an impossible study. It could be done because he was Archibald Cochrane. He did a randomized controlled trial with chest pain patients going to die. Mind you, they are chest pain. Randomize them to GP versus CCU. You think it's possible now? No way. But he did the study. He collected data meticulously and presented it to the Royal College of Cardiologists. And in that presentation, he put it up nicely. Nowadays, those days we didn't have any of the PowerPoint, okay? So the overhead projection or something he showed, and he put it there. And as it came, it is clear the mortality was much higher for the general practitioners as compared to coronary care unit. So the cardiologists congratulated him. What a brilliant study. And they said, this means we should ban general practitioners from looking after chest pain. And then this wily character stood up and said, oops, sorry, actually the data is actually this way. Actually, that study showed coronary care units were dangerous, okay, compared to GPs. And it's understandable, in that era, people did not know all these things. Okay, they will have a whiskey and take care of the chest pain by itself. And now suddenly they attach to all kinds of ropes and tubes. That was too much for them. Actually, they had a higher mortality. You can look up, the study is there. Archibald Cochrane on ICU versus CCU versus general practitioner. But what happened? CCU is one. Where there is money, that group wins. Science is not important. It is where the cash is. See, supposing you are introducing a vaccine, and you say after the vaccine there will be a fall in the proportion of rotavirus diarrhea. There you can estimate what would be a reasonable impact. Okay? So I think after the vaccination there will be a 10% reduction in rotavirus diarrhea. Impressed? No. You would like to hope it is much better. How much better? 20%? So you would like to calculate the sample size based on a reduction that you think is important from public health point of view. You understand? 50%, wow, that is a great reduction. So I would put it somewhere between 10 and 50%. I don't ask for 80% reduction. If it comes, well and good. But at least 50% reduction, I should be able to pick it up. I would even settle for 40%. You see? So that's why we judge that in terms of what is the impact. But that is one. But certain diseases you just follow up over time. And then you see what happened. Now, those diseases which are in steady state, okay, you say, okay, this is going to be a steady state. And then, if it falls, then you ask the question, what made it fall? And there are methods by which, for example, we have a problem with Japanese encephalitis. Every year we follow up and find out how many cases of encephalitis was reported. And then we see, is it growing too much? You remember the definition of epidemic, occurrence of disease, clearly in excess of expectation. So if I am getting continuously 9 cases every year in my area, I will say, oh, that is expected. But how do you say it is more than expected, less than expected? I'm going to tell you, you can forget it immediately after the class. I find the square root of 9, okay? And that is my standard error. And I put 2 standard errors on either side, 15 and 3. If it's below 3, it's clearly below expectation. If it's above 15, it is above expectation. I showed you a technique. There are umpteen number of such techniques. You understand? So it all depends on the purpose for which you are designing this follow-up study. He is asking, we use the random number table. Rand Corporation, is that the one?
Yeah, that's it.
Rand Corporation created this random number table. And it's got 1 million random numbers. And have you seen it? You should, because it's in your computer. I send it as one page of it. Okay? 1 page. When you're not feeling sleepy, you can read it. Okay? Now, those numbers are random numbers. What is so great about the random number? Random numbers are not haphazard numbers. They are truly random numbers. They follow a certain rules of randomness. And Rand Corporation checked and found it does. But the problem is, using the table is real pain. So that's why I showed this little thing. You have an alternative method. Instead of birthdays, because everybody keeps, are born on 25th, not a good idea. Okay? So, in fact, I was also born on a 25th, so I have sympathy for all the 25th. So if you get a random number generated, he could have generated for me, it would have become nicer. And then in ascendingly or descendingly, and this whole thing can be programmed in a computer. You can get a long list. This is not a random number, they are pseudo-random numbers, but still they do all right. Now I'm going to call this two standard errors is equal to D. And what is the D? This is called the absolute precision. I'm using the word D because all textbooks use D. Precision. The precision of the estimate of where the population mean is. In this case, it is plus minus 0.4. Absolute precision. Now, if I would write it again, your boss is unhappy. Boss says, listen, boss, you did not do it right. This is too wide. Do you think it's wide? No. But he is neurotic. He wants more precise estimate. How precise? You want not plus minus 4. I want plus minus 0.2. That is, I want it to be from 10.8 to 11.2, that kind of. No sensible person will ask for it, but he asks. How could you have done it? Could have done it by reducing the size of the sample size. Sampling error, standard error. And to do that, you need to increase the number of n. So this is the equation to see how to calculate desired sample size. He has already know that D should be 0.2. Now how to get this n out? He's got a square root there. When a square root comes, my mathematics breaks down. So what do? I quietly rub it off. That's the way. So there's no more a problem. But the 2 becomes squared, ST becomes squared, D becomes squared. But no problem. Now you can take out the n is equal to 2SD square divided by D square. So assuming you want a D of 0.2, what sample size would you require? Can you calculate it? D is equal to 0.2. Sorry. Thank you. Calculate sample size. It's a very commonly used equation. And what I said, this one is for continuous variable. A more familiar one you would have seen is for dichotomous variable, which is equal to 4pq by d squared. This is all used for prevalence studies. Again, the logic of the calculation is very simple. How precise should be your estimate? So when you go to a statistician, he'll ask you 2 questions. What is the expected prevalence? Don't shout at him. Don't tell him, that's what I want to know. No, you have to give some ballpark figure. Is it close to 50%, 5%, 80%? Something you should tell her. If you don't know, then don't do the research. Okay, you have to have some idea to do the research. So that's number one. Second is, you'll ask for how tight should be the absolute precision, plus minus. Okay, and this is equation for, we don't have to dwell in much because people know it, but you should look intelligent in front of them. So you should say, I want a plus minus, this precision, that precision. That's enough. I'm going to stop that with the sample size calculation. Did you get a number 400? Oh, you did correctly. Did anybody not get? You didn't get? You're trying to hide behind him? No, it won't work. The d square is 0.2 into 0.2. That confuses the hell out of us, right? Right. Okay.
So, how do you choose the one for B?
Huh? How do you?
Choose the B.
Ask your boss. But I tell you one secret. When it comes to dichotomous things, like disease, not disease, prevalence of disease, incidence of, in general, it's a PQ business. There, the absolute precision is not the important one. You have to think in terms of relative precision. So, relative precision is equal to absolute precision divided by prevalence. And we usually take in terms of 20% relative precision. Let me give you an example. If I think the prevalence is 50%, 20% of 50 would be 10. So plus minus 10 would be my absolute precision. So I started thinking about relative precision. From there, looking at the prevalence, I calculated the absolute precision. In the equation, you should never put relative precision. You should always put the absolute precision. Okay? Supposing relative precision, prevalence of a disease is 10%. Again, 20% is your relative precision. 20% of 10 is 2. Okay? Plus minus 2. Perfect. So, depending on the P, first think in terms of a relative precision, and the general rule in public health, okay, it's in public health, is 20%. Because the departments usually don't have money. So you have to settle for reasonably small sample size. If you have the money, you can do anything. Okay? Okay, now I have brought in the notion of standard deviation, standard error, confidence interval, and this how to calculate sample size. For the time being, that should be sufficient. I'm going to change over. Remember, when you learn to do studies and surveys and magnitude problem, you have to do how to do accurate measurements, worry about sensitivity, specificity. There's nothing called 100% sensitivity, 100% specificity. So you have to do with it. And within the parameters, you do the survey and get the best possible result. But very often, our questions are deeper. We want to study connections. Connections in terms of relationship between various studies. In fact, one of our most important passion is to find cause for diseases, causality. And it is not easy to think in terms of causally, because we never know the whole thing. So given the little knowledge, how do you study causality? Is there a way you can streamline it? And in thinking causally, you should remember people before us also have thought of it. But there are different ways. Practically everybody can figure out causes. Okay? All of us are very good at making up this. Right. There's a book this guy is showing by Leon Goddess. Just raise it up. This guy was my teacher. And a guide. So I had the privilege of meeting him every now and then, because guides are supposed to look at the student. First time in United States, nice to have. Very good teacher. But he told me a story. I liked it so much. And I told the story to everybody. And I hope my students will tell to their students. But remember Leon Goddess. Now, the story goes from the Second World War. During the war, the Germans started bombing the city of London. It was not a nice thing to do, but they did. And one night, the bombing was particularly heavy, and a whole building collapsed. So rescue workers went through the rubble and found a man trapped in a toilet. He was unhurt, but quite shaken. Guys asked him, "Are you okay?" The guy said, "I guess so, but you wouldn't believe what happened. I just pulled the flush and the whole building collapsed." Poor chap, he went around with the thought that he had brought down the building. But what happened was very remarkable. If human mind does this, if something is connected with another thing in time and space, we ascribe causality. Okay? You see a boy and a girl walking together, and it comes naturally to us. Okay? So we connect up, we make stories in our mind. Can't help it. And our life is full of stories. Okay? And, chicken causes heat, potato causes gas, and the world is full of these stories. How do you figure out which is real, which is not real? Now remember, the problem is, just by coincidence, just by chance, things can happen. But then you say causality. Okay? You connect it up. And I don't know how many times I do it, you also do it. Especially if you know how to play cards. Have you seen card players praying, "God, give me a good card"? I don't think God is waiting to give you a good card. But when it comes, thank God. Okay? So, this is the way our system works. You need a cause. If you can't find a cause, you ascribe to God, whatever it is. And that is the human mentality. But our science should be something greater than pulling the flush, okay? Something of quality. Is there a way of doing it? Plato, who was a student of Socrates, thought that all knowledge was within you. Wow, that's nice, right? Yeah, you're born with it. You don't have to come for a course and think like that, okay? Go, find some nice tree, sit under it and meditate, and it'll all come out. So epidemiology causes a waste. It's all inside you. And that group of thinkers is called rationalists. Rationalism. The other group was headed by his student. You know Plato, where is he from? Which nationality was he? Anybody? He's a Greek. Yeah, that area was busy fighting wars, everything. But Plato did a smart thing. He went out of Athens, just outside the city. He built a university. Okay? And that university was there for so many years. Plato was before Christ, okay? And Aristotle was a student. Aristotle also taught Alexander the Great when he was young. So we have an Indian connection there. But what I'm trying to say, Aristotle said, no, Plato is wrong. See, those days a student could tell this professor is wrong. Not now. Plato allowed it, okay? He said, knowledge is not within. You have to observe, measure, collect data, and then you become knowledgeable. So there are two schools. This one is called, Plato's thing is called rationalism, and Aristotle's thing is called empiricism. The study design that we do everywhere is called empiricism. But that's not what Plato was thinking of. And I remember the beginning of the class, I tried to bring out the meaning of the word fact and theory. And that is what the reflection of this combat is. Always thinking of where does the truth come from? So you can imagine Plato's line like a spider sitting in a corner, weaving his own web. Or Aristotle asking, like an ant, collecting data. Okay? But I think the true knowledge must be a combination of the two. Like in the case of a bee, collects nectar, and from the nectar creates the honey. So both are important. But I mentioned all these because behind all this there is a logic. The logic has got two domains. One is called deductive logic, another is called inductive logic. Deductive logic follows from rationalism. Inductive logic follows from empiricism. We all use it. For example, deductive logic. I went into a room, there were 400 people sitting there. And I said, at least 2 of you must have birthday on the same day. Could I be wrong? Birthday, you know, Gandhi Jayanti on October 2nd. Could I be wrong? Huh? Possible? Impossible. That is the beauty of deductive logic. Because in that statement, I use 2 axioms. There are 400 people sitting in the room, and there are 366 days in a year. If both are true, then what I said must be true. Because I assigned January 1st for one person, January 2nd for after 366 days, I have run out of days. I have to reuse a day because there are 400 people sitting there. So when I make a statement that way, it has to be true. In medicine, this is a mainstay of any logic. In creating new hypotheses, new paths, deductive logic is important. How does that inductive logic come? Data, collect data. For example, I want to know what is the color of a crow. How do I do it? I take a lot of paper, pencil, go out, crow, black, crow, black. After having seen 125,344 crows, I would say, all crows are black. And then I'll put it in a cover and post it. And as I turn around, a white crow passes by. Okay, what the heck? Are there white crows? Huh? Yeah, albino crows. But crows are very racist. The black crows don't let the white crows survive. Okay? So, anyway, the point I am trying to say is this. Axioms generally come from empirical data. So that is the source of our knowledge. But the wisdom is how to mix the empirical data and rationalize it to know the truth. And that is very often not seen properly. In other words, we need not just p-value significant to know the truth. It is never the truth. Okay? You have to take that I take further and say, what does it imply? So that is what we are going to search for. But I want to tell you something else in this context, in the evolution of science. Once upon a time, in Europe, all source of knowledge was with the clergy, Catholic priests to be specific. If you have any problem, you go and ask them, he'll tell you. And that will be the truth. I suppose in India also we had sannyasis where you went. So we went to them. But one morning, one guy called Fracastorius, have you heard that name ever? He woke up with a new vision. He said, I know what causes disease. I said, how? What is that? He said, there are small animals whom you cannot see with the naked eye. They cause the disease. Wow. If a priest says, it must be correct, right? And he gave it a name also, the theory of contagion vivum. The prevalent thought those days was something called miasma. Miasma means bad air, bad environment. Now started the battle between contagion vivum and miasma. Today we can sit and laugh at them because we know both play a part. But that time they wouldn't talk to each other. If the miasma guy had a pretty daughter who wanted to marry somebody from the contagion vivum group, no way, you are not marrying my daughter. That was the stubbornness they had. And they fought and fought. In fact, I think Istanbul, where Ashish is going to Istanbul, no? There was an epidemic of plague. And they've sent both groups went to investigate. And what did they come out with? The miasma group came with the impeccable evidence to know it is bad environment. And what about the contagion vivum group? Terrific evidence to show it is a small animal which cannot be seen by naked eye. Then came Louis Pasteur. Have you heard of Louis Pasteur? Which country? France. Okay. He was a true Frenchman. All his research, he was not a doctor, but he contributed tremendously to medicine. Everything with a focus on France. So he was always that French-oriented kind of person. And he showed, there are some little fellows you really can't see, but they cause disease. He showed it brilliantly. Okay, these are stories you should read about. But by the time, this Leeuwenhoek fellow had been meddling with the microscope. So people became more and more available, and people could actually peer down and see this little animal, okay, which caused disease. And then came the era of bacteriology. Everybody wanted to become a bacteriologist. You ask a mother, what is son doing those days? She say, bacteriology. Like in here in India, 5 years ago, software, So this particular trend came on, and poor fellows, the miasma group, they had to go back to church, okay, quietly and sit at the back. We are wiser now how these things combine. But the problem was, everybody was diagnosing or detecting, finding cause. Headache germ, backache germ, you name it, there are germs everywhere. And what to do? How do you know there are germs causing the disease? And Robert Koch and Henley came out with some rules. Koch's postulate. Heard of that? Anybody remember them?
You should be able to culture it, and it should re-cause the disease if you...
So there are two observational criteria. And the third one is a cruel experimental criteria. She remembers only that. Like most of us do, only the cruel one. That is, you sneakingly take it out, culture it, and when the other fellow is not watching, give a dose. And make sure he falls sick. And then you know it's a god. But the first two are the more important one for observational sciences. And the first one is, the agent should be present in every case of the disease. Number two, agent should not be present in the absence of disease. And I'm going to put it down on the table because that should be important. The epidemiologists all, without exception, keep depending on 2 by 2 table. We are incapable of complex thinking, okay? And so we do this 2 by 2 table. What I just now said, I'm going to put it in a 2 by 2 table. Disease present, disease absent. Agent, that is the bug, present, absent. A, B, C, D. Many of my students suspect I know only 4 alphabets in the alphabet. You know, 4 letters in the alphabet. Because A, B, C, D. It keeps coming back again and again. But look at this. First postulate demand. In every case of the disease, agent should be present. That means C should be 0. Number 2, agent should not be present in the absence of disease. The fellow hang around everywhere, then you can't call it an agent. So that means B should be 0. This is the true criteria. Who presented? Cox postulates demanded. Now, look at it again. B is equal to 0 means if the agent is there, you have to have the disease. There's no escape. In other words, it is a sufficient cause. What about this one? C is equal to 0. Without agent, you can't have disease. That means the necessary cause. So, Cox postulates that if you want to confirm a particular agent causes a disease, then you have to say, prove that is both necessary and sufficient. Now, any of you know a disease like that? Good. There isn't one. Okay. Now, I tell you one thing. All infectious disease have a necessary cause. But to make it sufficient, difficult. TB doesn't cause tuberculosis. You have to have other plethora of evidence. So we realize this is in big trouble. And also, it's lunchtime. As soon as Jenner came out with the vaccination for smallpox, the anti-vaccine lobby was born. And they still live. Are they essential? Absolutely. They have an important role to play. But those fellows immediately attacked. So finally, Louis Pasteur said, I'm going to do an open trial. What is the open trial? He'll do it in a farm where everybody can see. So he invited anybody who wants to see the trial, please come and see. There, he took 25 sheep and gave them vaccination. 25, no vaccination. Okay? And then another 10 sheep he kept in a different corner of the village. And then he went away and said, after some time I'll come and expose them to anthrax. And on the day this has to be done, whole lot of people landed up anti-vaccine lobby, veterinarians, newspaper, and our friend Robert Cox. He's also there. And sure enough, on the day our hero came and announced, I'm going to give the vaccine, anthrax live bacillus to all the 50 animals. And I assure you, all the 25 who have not been vaccinated will die within 2 days. And the remaining 25 vaccinated, none of them will die in that time. So a lot of excitement. One veterinarian put up this case. We don't want you to give a standard lethal dose of anthrax. We want you to give 3 times the lethal dose of vaccine, of the anthrax. That, what would Louis Pasteur do? Sure, why not? Go ahead. Real filmy style. You give him 3 times the dose, okay? Music went on, drums beat, and they gave everybody 3 times the dose. And everybody went home. They had to wait for 2 days. 2 days later, Louis Pasteur came. I'm sure he didn't sleep for 2 days, okay? And all the unvaccinated 25 were dead. And none of the 25 vaccinated were dead. All of them were alive. This model was vindicated. But I want to tell you another randomized controlled trial that happened subsequently, many years later. This is by Pfizer. The drug involved was Viagra.